welcome again for everyone who has logged in today. As I mentioned, feel free to introduce yourself in the chat. But we will get started today with a couple of housekeeping notes and then jump into our presentation about recovery in the workplace. So before we get started, as a participant on the webinar today, you will not have the opportunity to speak or share your video. However, we'd still love to hear from you. So if you have any questions, feel free to, for our presenters, feel free to put those in the Q&A function on the Zoom. It's at the bottom, the little icon that says Q&A. I'm sure everyone on this call is a Zoom expert by now, but we will be monitoring that Q&A chat function so that at the end of the webinar, we will address some of those questions. All right, so jumping into the session, I'd first like to introduce myself. My name is Maddie Morales, and I am part of the team working on the Life Unites Us campaign to reduce stigma around opioid use disorder. My role is to engage community organizations in this effort. So I'm especially excited to see so many people logging in today. Without all of your work, this work would really be worthless. So thank you for being here, and I'm excited to share some ways to get involved with the Life Unites Us campaign. So for anyone that is new, quickly wanted to introduce the campaign and share some ways to get involved. So Life Unites Us is a project developed to reduce stigma around opioid use disorder. And we do this using a people-forward approach that aims to connect individuals through stories. Through research and practice in anti-stigma work, we have found that connecting people through their stories and similarities can and will reduce stigma. So that is the why behind the Life Unites Us campaign. And the way that we do this is by our team records stories of community members across Pennsylvania, stories of both personal recovery and as an ally to someone in recovery. We then produce these short videos on our website and social media to be shared far and wide. Our intent is that by sharing stories of hope and resiliency, we can prove that recovery is probable, reducing stigma makes recovery more likely, addiction is treatable, and those living with an addiction are just like everyone else, and those living with an opioid use disorder are so much more than their disease. So I wanted to just show you what this looks like online. We can be found on Instagram and Twitter. So definitely come find us and like us, and on Facebook as well. And then we encourage you to also share your own story and sign up to be a partner and find the full story library where there's amazing stories from community members across Pennsylvania on our website. And this is our core project team. We are in partnership with DDAP at Penn State, Harrisburg, and Shatterproof. So partnership opportunities as an organization, you'll have the opportunity to both help us recruit stories and share stories to your community. We can include your logo on our website. We can share curated campaign videos with you. We'll invite you to these monthly webinar trainings like you are attending today. And we'll also make sure you have access to our partner exclusive resources. So all of partnership is free to join us, and we'd love to have you engaged in this effort. So if you're interested, feel free to send me an email. It's listed on the slides right now, or reach out via the website. All right, so now that we've gone over the campaign, I'm really excited to introduce our first guest on the webinar today. Danny Albert is coming to us from Hero in the Fight. And just to quickly introduce Danny, Danny is a person in long-term recovery. Dan understands the importance of upholding the rights of individuals in recovery, despite the stigma often associated with recovery and addiction. Dan recognizes and illuminates the positive aspects of conducting a life based in recovery from substance use disorder. His personal mission is to inspire and improve the lives of others. He aims to help others, whether they have a substance use disorder, are in recovery, have lost a loved one, or are family members impacted by the disease of addiction. I'm really excited to have Dan on the call today. He's going to share a little bit about his experience with recovery in the workplace before we jump into the presentation. So with that, I will pass it over to you, Dan. Welcome, and thanks for being here.
Thank you for having me. First off, it's an honor and a privilege to be able to do this. My name is Danny Albert, and I'm a person in long-term recovery. What that means for me is I haven't had a mind or mood-altering substance since April 30th, 2017. I'm the founder of Here on the Fight. For those that might not know of Here on the Fight, we are a grassroots organization created to break the stigma of addiction and raise awareness on the impact it has on individuals, families, and in our communities. Through Here on the Fight, we've been able to speak at the elementary, middle school, high school, and university level with students. We've been able to raise money for recovery housing scholarships. We've been able to give alcohol-free hygiene items to individuals entering facilities, going into recovery housing. And through that, we have our group page on Facebook. It's a real-time resource for inspiration, strength, and hope. That being said, I'm from Steelton, Pennsylvania is my hometown. Very proud of where I come from. For those that don't know about Steelton, we're a small town with a big heart and a melting pot of ethnicities and backgrounds. In school, I managed to graduate high school with a full ride academic scholarship. I went to Millersville University, and my progression of substance use elevated year over year. And when I got to college, my substance use was the catalyst for me dropping out of college within my first year. And remember, my mom and dad picking me up from school, and I sat in the back seat. And on that ride home, everyone that didn't believe I deserved that scholarship, I proved right. The expectations that others put on me, I didn't live up to. The expectations I put on myself, I didn't live up to. And I went home feeling defeated. And living with my parents, I decided to get a job in the restaurant industry. Over time, I went from server to bartender, and I went from one restaurant to another. And at Charlie Brown Steakhouse, I was given the opportunity to be a manager, right? There were a few things that I do well. I'm good at inspiring other people. Through my addiction, I'd learned how to become a better salesperson. And those attributes are what provided the opportunity that someone saw in me and gave me that opportunity. And from there, I left Charlie Brown's because it closed down, and I became a kitchen manager at Red Robin. While there, I had a daughter. And at that time, my opiate use was at an all-time high. And I ultimately became fired from that job. And my opiate use went to IV heroin use. And I got a job at the Harrisburg Melting Pot. Now, at the time at working at the Melting Pot, my daughter and her mom had moved to Philadelphia, to protect my daughter. And at that time, my mentality was I didn't care to be alive anymore, but I cared too much about using the substance to want to take my own life. And I say all that so you have an understanding of a little bit about me when I'm at the Melting Pot. So working there, ultimately, a lot of the never will I evers started happening, and I started using at work, which wasn't a thing that I would do. It was always before or after. And ultimately, the owner pulled me into the office, and he gave me two ultimatums. One, I can either go to treatment, or two, he's going to have to let me go. And here's the thing. He said, if you decide to get treatment, I will do whatever it takes to get you into a treatment facility. And I left that conversation and I walked home. It's a 45-minute walk. And on that walk, I thought about all of the things in my life, right? I'm 28. I'm living with my parents. I'm walking home because I was getting rides to work from my mom. I wasn't able to see my daughter. I didn't have a healthy relationship with my daughter. And I made the decision to go to treatment. And while there, I actually left that facility early and I AMA'd. And when I came home, I told my employer and everyone around me that I completed treatment, and they were all proud of me. And um, not long after, I went back to a substance, and I was ultimately fired. Um, I'd go on to get kicked out of my parents' house because my dad said he didn't want my mom to have to watch me die. And I'd go from couch to couch and burn relationship after relationship. And I ended up living out of my Chevy Blazer. And in the in that, I had what little clothes I did. I would use them for a pillow and covers. And I went to the Cork and Fork restaurant and I applied to be a server. And I was hired. And a month into that, I called the owner and I said, I need to get help. I'm going to go to treatment. And he said he would keep my job for me and to take care of myself. So I went to that facility and I completed it, short-term program. And I came back home. And when I came back home, my family said that they couldn't support me anymore. I had to move on from any relationship that I had at that time because they weren't healthy for me. And I felt all alone. And when I got back, the owner said I could call him every day on the phone. And that's what I did, right? I would call him for only 5 to 10 minutes about feelings I had, things I was going through. And he was there for me, right? And as time went on, I asked him if I could be a manager. And the longer I stayed in recovery, he gave me that opportunity, right? Like he believed in me before I could believe in myself, along with other employers in the past. They saw something in me, but I didn't see it in me. Um, so what I would do is I started going to the gym with him, and he would take me to different restaurants that he owned in the city of Harrisburg. We would stop by Cafe Fresco. We would go to Home 231. And, he was a mentor for me. And over that time, now I am the assistant general manager of the Cork and Fork franchise. I'm entrusted to do the payroll for employees. That level of care that was given to me, I am able to in turn do for others, right? We've been able to employ individuals in recovery. We've employed family members in recovery. There is a culture at the restaurant where when we have a wine tasting or a new drink, no one is made to feel like they need to try those items. And in my experience in the restaurant industry, that has not always been the case. Over time, other restaurant managers and employees have come to me and confided in me things that they were going through. And they know that I'm a safe space and that I can help facilitate resources for them. And they trust and know that they're safe with me. And they know ultimately that I care. And that level of care is something that we've been able to cultivate at the Cork and Fork restaurant. I know what having uncomfortable conversations look like because I've had one at the Melting Pot done to me. I'm able to take all of these experiences and provide and empower individuals the same way that was done for me. And it creates a healthier work environment. It lets people know they're cared about. And I am a direct reflection of what recovery in the workplace can do for someone else. Thank you for letting me share.
Thank you so much, Dan. That is a really, really powerful story, and appreciate you sharing all the aspects of your journey. So thank you for being here. Well, with that, I wanted to move on to our next featured speaker here. But first, quickly wanted to introduce, share a quick note about Project Echo, who also helped us in bringing our speaker here today. So Project Echo is a virtual learning community where participants receive expert mentoring and feedback. Together, specialists and community providers collaborate to discuss patient cases and develop recommendations for care. Over time, participants become experts, engaged in a wider community of learners, and empowered to address complex conditions. The training topics span quite a wide variety, as you can see on the slide here. And especially around COVID-19 services. So if you're interested in more information, please reach out to echo@psu.edu, and that will also be dropped in the chat so that you can reference it there. All right, so last but not least, I would like to introduce Dr. Kawasaki. She is the Director of Addiction Services at Pennsylvania Psychiatric Institute and Assistant Professor of Psychiatry and Internal Medicine at Penn State Hershey. She designed and directs Advancement in Recovery, an opioid treatment program at the Pennsylvania Psychiatric Institute in Harrisburg, Pennsylvania. She's board certified in internal medicine and addiction medicine and has extensive clinical experience in both primary care and addiction medicine, and a career interest in research to improve the delivery of evidence-based treatments to addicted patients in community-based treatment settings. So I will let her share some more about her work and research today. We are really grateful to have her expertise on the webinar today. So I will stop sharing my screen so that she can share hers, and welcome.
Thank you so much for having me. I hope everyone can hear me and my sound is good. I'm going to share my screen.
Your sound is great.
Great. So today I'm going to talk about methadone. I'm just going to spotlight methadone treatment and clear up some myths, as well as give some facts on what methadone recovery looks like, and then talk about stigma in what may be perhaps a slightly new way to think about it before I wrap up. So I'm going to go over what is methadone, what the evidence is for it in the treatment of opioid use disorder, what are different stages in recovery on methadone, and describe examples of stigma in terms of the way medical systems approach opioid use disorder, and by contrast, sort of what employers would do as well. The importance of using appropriate language and terminology. So to discuss the treatments for opioid use disorder, it's really important to understand the difference between addiction and dependence. All too often, you'll see people talk about the medications for opioid use disorders as trading one addiction for another. And that is not the case, because addiction is a very different illness. It's a brain disease that is characterized as people dealing with craving, pathologic craving, which will lead to use despite adverse consequences such as jail or family obligations, social obligations, death, sickness, being hospitalized with problems. And so using in spite of all these very real consequences and spending a lot of time thinking about using and how to continue to use is all a part of the disease of addiction. And this can be readily identified on brain imaging versus dependence, which is a condition where if you stopped a medicine, you would get sick. And so you would see that in medicines that create dependence, such as opioids or other controlled substances. But you would also see it sort of less in a different way with any medicine you need for a chronic illness, such as high blood pressure or diabetes. If you stopped your medicine abruptly, you bet you'd be seen in the emergency department with complications of those issues. And so dependence really means any medicine that you need to stay healthy. And so these four areas of the brain are why there are addiction specialists out there in the world. These areas, the anterior cingulate cortex, little biology, nucleus accumbens, the thalamus, the periaqueductal gray, these parts of the brain produce dopamine in response to opioids. So this is what lights up, this is what creates the dopamine, this is what creates the reinforcing behavior behind addiction. And we know it's bad because this has really been a problem for a long time now. And people have died, and in alarming rates, just really alarming, gone from 4,000 20 years ago to 72,000 3 years ago. And the graph on the left looks at the United States Caucasian population in this red line in comparison with similar populations across Europe, where deaths are decreasing in these countries, but in our country it's increasing. And when you stratify the causes of death on the right, you can see that the lines that are going up as you go to the right show poisonings and suicides and chronic liver diseases as causes of death that are increasing at the same time, all of which can be explained by drug use. So this is really important. And I want to say that substance use disorders and opioid use disorder has been a problem in inner cities for decades, in Black communities and in communities of color. And it's really only become a national issue when the changing face of the demographic incorporated more Caucasians. So we really need to be collectively ashamed of ourselves that we're now in the public health phase of opioid use disorder, which is really what it always should have been. And it's something that we need to take with us as we move forward in this. So why is it bad to use opioids other than death? It can cause lots of morbidity, such as HIV and hepatitis and hospitalizations. And all of this is to say that the medications work to prevent these illnesses and to prevent your workplace from being, staffed by people who could potentially give these illnesses to customers. And so how does methadone work? So when you're talking about initial use or acute use, you have your normal and you're using to get high. And so that is initially what it looks like. But then with time and with tolerance and physical dependence, people are using to avoid getting sick. And so they're using and feeling normal. And then when they don't use, they start to feel sick. And so this is what medication or methadone does, is that it really just sort of stops this rapid cycling and instead keeps a constant feeling of normalcy. And so what are the three medicines that treat opioid use disorders? So I just want to pause briefly here and say that we have 20 different treatments for strep throat. And for opioid use disorders, we really have three. And of these three, only two really work. So it's important that we not develop feelings or opinions about either one of these medicines that work really well, because they save lives, and I'll go through it. So methadone is most chemically similar to opioids of abuse, including heroin. Buprenorphine is the active ingredient in Suboxone, and that is a medication that I'm sure you're all very familiar with. And naltrexone is a blocker. It is a long-acting blocker, so different from naloxone or Narcan, which is a rescue medicine. Naltrexone is a long-acting version of that blocks opioids. And so what do we know? What does it mean when I say evidence-based treatment? What is the evidence? Well, how researchers look at that is they want to make sure that the medicine can keep people alive, it can keep people in treatment, it can keep people out of jail, and it can keep infectious diseases such as HIV and hepatitis from being transmitted. In other words, the medicine is so powerful that it reduces the high-risk behaviors such as sex or injection drug use that cause these infectious diseases to be transmitted. And so I'm going to start with methadone and just, ask the question, so does methadone keep people alive? Absolutely. So this was a study that followed individuals over 20 years all methadone treated individuals versus people that had counseling alone or detox and counseling, and found that far and away people on methadone treatment lived much, much longer at higher rates than people with opioid use disorders that weren't given constant methadone treatment. On the right, ask the question, how long do people need to be on methadone? And the answer is as long as they need it. So the top line is a show of how many people are alive over the course of 8 years when they've made the decision to come off of methadone because either they don't know anybody using anymore, or it doesn't make sense with their life anymore, or they've accomplished so much they want to do other things. These people did very well. But contrast that with an involuntary discharge where maybe insurance was cut off or a physician was saying, hey, you've been on this medicine for 2 years. You should be better. It's time to come off, or some other reason. And if they were discharged off of these medicines against their will, they did as badly as if they never had treatment in the first place. So really important that it be patient and provider shared agendas, so that people understand that. We don't tell people with diabetes, hey, it's been a year since you've started insulin. We've talked about lifestyle and diet. It's now time to sew your mouth shut. We're going to stop your insulin. We wouldn't do that in medicine, and we shouldn't do that here, and yet we do it all the time. Does methadone keep people in treatment? Absolutely. This is a study from 1979. And I want to let you know these aren't the only studies. There are 10 studies that go along with this study. And it absolutely does. Compared to detox and counseling alone, the people in the treatment group were much more likely to stay in treatment. 76% more like so 76% versus 10% in the folks that were not getting consistent treatment. And so that's really important. Does it keep people out of prison? I love this study because it's so old. It's from 1969. Methadone's been around for decades, and we know so much about it. And this is a study that looked at folks that were discharged from prisons. Some were started on methadone and some were not. And almost all the people who were not started on methadone landed back in jail versus a quarter of the people who were started on methadone treatment. So methadone really kept people out of jail. And then finally, to hit this home, that this was a review that looked at 8,000 total methadone patients and found that it significantly reduced the high-risk behaviors that cause disease transmission. And so much so that methadone clinics have to be considered a part of any municipality's public health plan, so that people understand what treatments are available to avoid these infectious diseases. So what are the different stages in recovery for methadone? So I want to let you know that in the first few weeks of treatment, there's a slow ramp up of medicine. The body takes about 2 weeks to figure out how to get rid of methadone. And so because of that, we can't increase it too quickly or we will kill the patient. So it's gradual. It's every 2 to 3 days dose increase. And during this time, the patient may still be sick or using. And so it's like, I would say it probably takes about 3 to 4 weeks to get to an ideal dose, but sometimes it can take up to 2 months. And after 1 to 2 months, they will feel normal and capable of a full workday. With sustained recovery, methadone clinics will allow for take-home doses. So it is a daily observed therapy to start, where folks need to come into clinic every day and get their doses administered to them. But with time and with negative urines, they are able to get bottles. And then you don't have to come into clinic daily. You can get up to 1 month, but that varies state to state. And with COVID, there have been significant adjustments made to that for stable patients. So I want to say that methadone has the best, the oldest, and the robust evidence for recovery. So buprenorphine, by contrast, is much newer, and it doesn't keep people in treatment in the same way that methadone does. So it's really important to understand how methadone works for folks that are not doing as well on buprenorphine and may need extra care. Um, People successful on methadone look like everyone else. There's so much stigma for methadone. They don't want to look quote unquote knotted out. I'll tell you, those folks are abusing other drugs. The people that are stable on methadone treatment actually are doing very well, and you can't tell. It can take 1 to 2 months to achieve stability, and how long they're on the medicine is determined individually. So we shouldn't stigmatize life-saving treatment. This is really key. Okay, so I wanted to talk about changing language, stigma, and go through a few thought experiments on how we treat substance use disorders as a society, so that we could see how absurd it all can be. And so, at the core of this is that substance use disorder is a prevalent, treatable chronic illness, that stigma results in gaps between science and practice, and sometimes language can perpetuate stigma. As we all know, substance use disorder is highly prevalent. Almost 1 in 12 had a substance use disorder in the past year. That drug deaths are increasing. We all know this. Primary brain disease, we talked about this. Any chronic illness is long associated with persistent and recurring health problems. There's no definite cure, requires ongoing medical care. You could say this about high blood pressure, diabetes, and also substance use disorders. It is heritable. It's influenced by environment and behavior. So it's, in the genes, as well as influenced by the surroundings, just like any other chronic illness. Without adequate treatment, it can absolutely progress and be lethal. And it should be noted that, as in other chronic illnesses, relapses or recurrences are very similar, as well as adherence to medication. So important to understand that. While they'll look differently, they'll present differently. Somebody who's not taking their blood pressure medicine versus somebody who's not on their medication for opioid use disorder, it's the same idea that adherence is difficult. Substance use disorders change biology. On the left, this is looking at heart metabolism and coronary artery disease, and brain metabolism on the right with an addiction. And so, why is addiction treatment, though, treated like it's a knee replacement or a heart attack, as opposed to high blood pressure? Both require ongoing care, and you can recover. Recovery works. So, with a significant amount of time abstinent, the brain can look normal again. And so, what is effective treatment? It's a wraparound service, and that's what we can offer. There are medicines to help with alcohol use disorder, opioid use disorder, tobacco use, and cocaine use, although that is less effective. But there's no cure, and so the best we can do is supportive care at this point, just like any other chronic illness. How long should treatment last? It should be individualized. And we need to learn from HIV/AIDS, where there's still no cure, but there is medication to really help control it. And so therefore, we need to destigmatize the treatment and get people into care. So this is really important. For me, the most educational experience of the past 3 decades was to learn that the traditional image of the addict is totally false. This myth has distorted public policy for 70 years. There is lots of proof that the treatments work, and I've only given you a taste of the studies that show that they work. And so this gap between the science and the practice marginalizes the illness and also causes actual policies to be enacted that set these folks back. So what if we treated other diseases the way we treat substance use disorder? Let's see what happens. Okay, so you go to the hospital with chest pain, you're found to be having a heart attack. Were you told it's your fault because of your choices? Were you denied treatment because you did it to yourself? Were you given a list of heart doctors and cath labs to call on your way out the door? Were you only given aspirin if you agree to go to counseling? Or were you kicked out of the hospital for more chest pain? So in other words, they're kicked out of the hospital for the reason that they're coming. So what if we treated substance use disorders the way we treat other diseases, where the only prerequisite for treatment is having a substance use disorder, where the system exists to offer treatment on demand, where care is triaged based on who needs it the most. You're not fired for having symptoms of the disease, in other words, relapse. You're encouraged to go on medicines, and you're offered a menu of treatment options. So there's so much stigma, and stigma is everywhere at every level, with health workers, with employers, with treatment providers. The stigma for the treatment is everywhere. So it's really, really important to address this. So two main factors influence stigma. Stigma decreases when it is understood that substance use disorder is an illness. And so we use these other words to describe people with other illnesses: victim, afflicted, fighter, survivor. But with substance use disorders, they're clean versus dirty, they're an abuser, and we need to change that. And so this is really important. What is abuse? Derived from the word meaning wicked act or practice, a violation of decency, and it's associated with other behaviors such as rape and child molestation. So professionals are more likely to view a patient as deserving of punishment if they're described as a substance abuser. And so there's stigma everywhere, from within, from the recovery community. Medications are viewed as a crutch or trading one addiction for another, and just choice versus disease, and stigma from clinicians where they believe that treatment is ineffective. But I've shown you that it's quite effective. So examples of stigma that we have: halfway houses where people aren't allowed to be on medicine for substance use disorders. They may not be offered organ transplantation. People mandated to treatment as a condition of probation who have positive urine drug screens, even if they have adherence to their treatment, can be put back in jail. That's an example. There are barriers to jobs, and it can stop people from seeking help. So these are all really important. We want to avoid terms like dirty and clean, abuse and abuser, and we're talking about treatment for opioid use disorder, medication assisted treatment. We don't call diabetes insulin assisted treatment. So we want to just call it treatment. And we should call detox medically supervised withdrawal. So words really matter. We want to avoid calling someone an abuser as opposed to a person with a substance use disorder. We want to call them a person in recovery as opposed to clean, abstinent, not drinking or taking drugs. And we don't want to use clean versus dirty. We want to say positive or negative. So many people, including some policymakers and authorities in the criminal justice system and treatment providers, have viewed maintenance treatments as substituting one substance for another. And they've adhered instead to an abstinence-only philosophy that avoids the use of medications, especially those that activate opioid receptors, like methadone or buprenorphine. And this is really important. This has led to a lot of policies to be passed, and it trickles down to employers' attitudes, to attitudes that really affect the well-being of people in recovery. And as well to physicians who don't want to treat these patients. And so this slide shows that there's a real gap in people, physicians who are able to prescribe buprenorphine and the ones that are not and haven't completed the extra training for it. And even the people who have completed the extra training, they're not treating enough patients. So, first, physicians themselves must change before they can help patients change their lives. And so it's really important. Um, uh, is this a disease or a sin? And everybody needs to get with the program that it's a disease. Hospitalized patients, patients that are hospitalized for other reasons, but also have substance use disorders, feel stigmatized. And so this is important. So these are examples of patients that were hospitalized and were stigmatized. And so family and friends can learn about addiction. I've touched on the science behind treatment, but there's a lot more for you to read up on. And that's all I have to discuss. So I think I'm well within the time, and I'm happy to take any questions.
Yes, thank you, Sarah. Dr. Kawasaki, that was fantastic. So much great information. Really appreciate all of that being put together. We do have some questions coming in from our participants, so continue to add those to the chat as they come to your minds, participants. But in the meantime, we have a couple questions on specific research, specific items. So one, what are the stats of people going off of methadone and not picking up other drugs or alcohol? Do they stay in sustained long-term recovery? Do you have any information on that?
It's a complicated question with a lot of answers. And it's also one that's being actively investigated still. So we haven't finished writing the book on this at all. I would say that it really depends on your level of recovery, whether you have been able to obtain employment, whether you have significant sober support, whether you're in a place where you no longer know anybody who still uses, and if you've had a really shared agenda, shared decisions made with your provider on slowly discontinuing methadone. For people that are highly motivated, it works. Individuals are not statistics. But a lot of the time, it is a medicine that needs to be on for life. Much of it has to do with how long you were using before starting treatment, because the brain really starts to fix as needing an opioid of some sort after a certain point. So for example, if you've been using longer than you have it, the chances are that you may need to be on methadone for the rest of your life. But if you've only had 2 to 5 years of opioid misuse or addiction, then you probably won't need methadone for that long. So it really depends on the patient, but in many instances, it will be lifelong therapy, and that's okay. It's really my job to say, hey, that's okay. These are folks that are staying out of jail. These are folks that are able to be grandma, grandpa, mom, dad. These are folks that are able to have housing and, money, and people that are able to live well.
Yeah, that's a great point. And that also makes me think a little bit about the specific topic of recovery in the workplace, and to speak sort of to Dan's experience as well. Is there anything that you can share as what can employers do with this information? What can employees do to support others with this information? So do you have any ideas for that?
I mean, I think it's important to understand that medicated assisted treatment is a pathway to recovery, and not to place stigma on that. And that, because recovery process is unique to that individual, right? Because what might work for one person might not work for another. And just understanding and knowing those things is really important, in my opinion.
That's great. So another question, what do you know about the use of fentanyl and methadone maintenance?
Yes. So with methadone, if you use any opioids on top of methadone, you can die from overdose. And so specifically in the central Pennsylvania region, and it's a regional issue where there's a lot of fentanyl in the heroin, there is a considerable risk of overdose if people are still using fentanyl on top of methadone. However, fentanyl is 100 times as powerful as heroin, and people who have a fentanyl dependence are extraordinarily tolerant. So if you're using regularly, the chances of overdose are actually pretty rare. If it's a relapse issue, however, in other words, you've been on methadone and haven't been using in a long time, and then you suddenly pick up with the amount of fentanyl that's in the dope, the chances of overdose are much, much higher. But the same goes with extended release naltrexone, which is the opioid blocker. And so if you've been on that for a while and don't show up for your injection at your appointment and you pick up and use again, the chances of overdose are extremely high. For detox programs, 28-day programs, people go in to come off of opioids, they lose their tolerance, and they come back and they go out and die. A great piece written 6 years ago called Dying to Be Free in the Huffington Post talks a lot about the stigma of medication and what happens with these some of these rehabs that don't allow for medicine. So it is a big problem, overdose, but more of a problem with relapse as opposed to ongoing use.
I see. Thank you. The next question I'm actually going to kind of crowdsource a little bit here. So if anyone has ideas on answers to this question, if you could put them in the chat. Someone is asking if there are any specific trainings available for businesses if they are interested in hiring people in recovery. I know that we have work or Pennsylvania friendly workplaces on the call today. So if you have any ideas, feel free to add those into the chat of specific trainings for folks interested in hiring people in recovery. Awesome. Another question also, this one I'm gonna lob over to Dan again, but someone is talking about their experience working in the service industry and something that you mentioned as well, how it's very prevalent and almost encouraged to socially drink together and hang out after work, or be kind of party and hang out, be fun. So what would be a good first step that management can take to acknowledge this issue and how they can start to support their staff that feel like they don't belong if they're in recovery or want to seek recovery? Do you have any first steps for management? What can they do?
Yeah, I think, ultimately letting employees know that they're cared about. And that's done just by the way you operate your business and you treat people, right? You treat people around you like that, then employees will start to see that. And for employees, for myself, I was upfront and honest. I let everyone know that I was in recovery, and the atmosphere was already established there. And no, they didn't. Employees, coworkers didn't ask me to go out to, a nightclub or things like that because they respected my boundary, right? And I think that that's important too, respecting boundaries of employees. Those things are what create a healthy recovery workplace environment.
Yeah, those are great ideas, really great ideas. Another rumor to address, and this one is for Dr. Kawasaki. Can you address the rumor of the connection between methadone and bone marrow damage?
Yes, there is none. So, so it's not necessarily bone marrow. Some people say it, quote, gets into your bones and it makes your bones weak. This is not actually true. Bone density is something that is a inherited trait. Sometimes when folks have been using for a long time and they experience lots of overdoses, or they're knotted out a lot in their use, they can lose bone density because they're just not walking, they're not upright. And so that is a function of their use and not their recovery. A lot of people think methadone damages their teeth, and some of them are confusing that with methamphetamines, the other meth, as well as a lifetime of dental neglect. So people are not known for dental hygiene when they're using drugs. And so what I call the dental phase in recovery is when folks acknowledge that their teeth hurt and they need dental care. And so I absolutely get them in to see a dentist because that's really, really important. But all these myths I go into in exquisite detail with patients on the first visit. So regardless of what medicine they start, so that they're familiar with all the different medicines and that I can help detangle any internal stigma they may have to one medicine versus another. Great question.
Thank you for clearing that up. Thank you. Do you have any information? What do we know about the long-term side effects of staying on methadone?
Largely, and I don't mean to be tongue in cheek, it's longevity. So people stay alive when they're on methadone. There is no sort of long term, it will cause lung disease or heart disease or dementia or anything like that. People at this point have been on methadone for decades, and so it's been well looked at, and people can be on methadone for the rest of their lives with no impact on their life expectancy. The biggest impact on life expectancy, far and away, is smoking. So smoking, and then also if they have hepatitis C, not getting that treated, and or drinking on top of it, which can lead to liver problems.
Gotcha. Thank you. One more question. Can you talk more about your statement that 2 out of 3 MAT actually work?
Yes. So methadone is the oldest medicine. Buprenorphine was approved for use in the United States in 2002. And these medicines have been shown to positively influence how long people stay alive on it, how long people are in treatment. Whether it keeps people out of jail actually is only true for methadone folks and not people that are on buprenorphine. And does it keep infectious diseases at bay? So those two medicines have shown that they are quite successful in doing that. Methadone's slightly better than buprenorphine, but they both work like gangbusters. Now, Trexone was a medicine that was made into extended release form in 2012, primarily for alcohol use disorders. That is the opioid blocker. But alcohol, unlike opioids, is a more promiscuous drug in the sense that it works on several different receptors. And so for people to use extended release naltrexone, for some people, it really works against alcohol use disorders. So at a certain point, the makers of extended release naltrexone looked at the, were considering, expanding its use to treat opioid use disorders, and found that they had quite a market in the politicians and law enforcement that felt that methadone and buprenorphine were rewards and did not meet their definition of how they envisioned sobriety should look like. And because they had done one study in 2016, so we're talking 5 years ago, that looked at people who were in prison, so people who were not using forcibly, and gave an initial injection of naltrexone in prison and then followed them out in the community. And they found that folks that were in the community getting the injections did much better, did not relapse, did not have overdose, than the folks that did not get those injections. Now, this was not compared with buprenorphine, it was not compared with methadone, but this treatment led to not only hosannas for naltrexone, but it saw an influx of money and influence and preference from politicians and law enforcement to continue it through. Never mind that when these studies were performed in the community, they found that not only did people, the average length of treatment was 1 month, in other words, one injection. So not even any results to move the needle in terms of keeping people alive, keeping people in treatment, keeping people out of jail, keeping infectious disease risk at bay. So it did none of those things because people weren't showing up for their injections. But um, uh, um, it's really a medicine that should probably be used for salvage treatment when people come off of methadone and and or buprenorphine and want to just have a security blanket for the following year. I think it's a great medicine to use for that. I think sometimes it's a great medicine to use for people who've been in recovery for a long time but are starting to have cravings and they don't have HIV or hepatitis. So, for those individuals who could start with naltrexone and other lifestyle modifications to keep them off of medicine, but the evidence just isn't there for naltrexone that it is for buprenorphine and methadone to meet those 4 parameters.
Thank you. That is very helpful. Well, we are almost at the end of our session here, but so much great information. Thank you for sharing today. The last thing I wanted to share with everyone on the call is that if you are interested in getting more involved with the campaign, please reach out to myself or to the campaign. And also, if you are interested in sharing a story of recovery or as an ally, just drop your email in the chat box or send it to us directly, and we will follow up and connect directly with you to get that story recorded. So last but not least, thank you so much again to our panelists today. A solo round of applause. I'm sure everyone else is clapping in their behind their Zoom cameras as well. But thank you to everyone for being here today, and appreciate all the work that you are doing to end stigma around opioid use disorder. Thank you.